Thank you, and it's a pleasure to be here. As a disclaimer as well, I'm not a cardiologist. I'm a psychologist who has been studying blood biomarkers, or as someone over dinner put it very affectionately, I'm a literal bloody psychologist. So to contextualize this talk, really, we have been aware that atrial fibrillation has often been seen as a disease of the myocardium, which can be driven by metabolic stress, channelopathies, as well as changes in genes that are implicated in AF. However, it is now more and more recognized that there are other cells within this cardiac microenvironment, including adipocytes, immune cells, stromal cells, endothelial cells, that sense and respond to changes in those cardiomyocytes. So there's this active crosstalk between the cardiomyocytes and the non-cardiomyocytes that promotes adipogenesis and fibrosis that act as the two major substrates for atrial fibrillation. Within this microenvironment, several factors are secreted and released into the bloodstream. So when we take blood samples from patients with atrial fibrillation, it offers us the possibility of detecting a novel biomarker signature, which we then can use to predict the presence of AF or to prognosticate AF-related outcomes. So for the next few minutes, I will highlight the recent literature on biomarkers, especially from the past 2 years, then describe some new markers that have emerged for identifying patients with prevalent AF, markers which might indicate who could respond positively to catheter ablation, and some observations of biomarker changes pre and post ablation, then conclude with some points for consideration. So to recap our discussion in the previous consensus conference, we emphasized that the ECG remains the gold standard for evaluating patients with AF, but we highlighted the importance of plasma biomarkers for assessing dynamic risk factors in AF and enabling the prediction of AF outcomes where the ECG is not available or feasible, for example, in community settings. We also discussed which biomarkers show promise for implementation, and of course, the natriuretic peptides and troponins remain our cornerstones. We also noted at that point of time in the literature that there were more biomarkers that were being explored, and these markers implicate diverse disease mechanisms we know to be involved in the development, maintenance, and recurrence of atrial fibrillation. In particular, we noted ST2, GDF15, cancer antigen 125, galectin-3, as well as fibroblast growth factor 23. So since 2019, the publications on plasma biomarkers have continued to increase, and indicating a sustained interest in the study of these markers, and several new ones have emerged. I will mention a few here, but the list is not exhaustive. Yeah, I have to highlight that. So the first marker, which I will mention, is something called total NT-proBNP. We are very familiar with NT-proBNP, but here this is a new assay which could measure both the glycosylated and non-glycosylated form of NT-proBNP, and this was investigated in the GC-AF study, and it was found that total NT-proBNP performs just as well as the classical NT-proBNP assays in its association with prevalent AF or prediction of recurrent AF episodes. And this provides us with new options for measuring NT-proBNP. The second study looked at insulin growth factor 1 and insulin growth factor binding protein 1 in the Framingham heart study. IGF-1 is known to be involved in cell metabolism, proliferation, and apoptosis, whereas IGF-BP1 is one of the complementary proteins which interact with IGF-1, basically. And here, lower levels of IGF-1 and higher levels of IGF-BP1 were associated with incident AF. This third study I will mention was done in the Aristotle and then validated in the RELY trial, identifying osteopontin, sortilin, and trefoil factor 3 in these two cohorts, in addition to NT-proBNP and soluble ST2, which were found to be associated with the risk of ischemic stroke in patients with AF. Fourth study identifies bone morphogenetic protein 10. This is a polypeptide from the TGF-beta superfamily. It is atrial specific, and in this study was a strong marker for predicting recurrent AF at 1 year post-ablation. Final marker I will mention is angiopoietin-2, which comes from a family of signaling proteins that play a role in vascular homeostasis. It's released by the endothelial cells in response to inflammation and vascular damage. And in this study of the Birmingham and Black Country Atrial Fibrillation Registry in the UK, was shown to be elevated in patients with prevalent atrial fibrillation. So I'll now go into more detail for some of these markers. I'll start with the study of the Birmingham and Black Country Atrial Fibrillation Registry, where we had 1,485 patients in a secondary care setting. And we wanted to find actually a combination of markers, not just a single marker, but a combination of markers and clinical characteristics that could help us to discriminate between patients who have AF, so diagnosed with AF, and patients who have cardiovascular risk factors similar to patients with AF, but were in fact in sinus rhythm. So we used classical regression models and identified a combination of age, sex, and BMI, plus 3 biomarkers, angiopoietin-2, BMP10, and fibroblast growth factor 23, which best identified the patients with atrial fibrillation. So using the same data, we applied this deep neural networks that Stefan was just mentioning, and use a procedure called SHARP, which helped us to interrogate this black box a little bit to understand which variables were actually influencing the outcome in the deep neural networks to quantify the influence on the outcome. And here we see a ranking of the variables of interest from neural networks actually replicated what we found in classical statistics, giving us quite a lot of confidence for the biomarkers that were emerging. Finally, one thing we also noted was that when we looked at the heart rhythm during the blood draw for these patients, of the 12 biomarkers that we studied, BMP10 was the only one which was significantly elevated in patients who had diagnosed AF, but were in sinus rhythm during the blood draw. So this is mimicking patients who have paroxysmal AF and at the point of the blood draw were actually in sinus rhythm rather than in arrhythmia. So this suggests to us that it could be a promising marker to discriminate between patients with AF compared to patients with other cardiovascular diseases. This next study in the AF-LMU cohort looked at 359 patients with AF who were indicated for catheter ablation. So here we wanted to identify biomarkers to predict recurrent AF, which occurred in approximately 43% of the patients within 1 year of follow-up. When we compared these 12 candidate biomarkers, and here we look at the analysis which was also adjusted for age, sex, type of AF, and left atrial diameter, we found that BMP10, GDF15, FGF23, and troponin T were predictive of increased risk for recurrence. So we were quite intrigued by this BMP10 because it's a rather new marker here. So we stratified this BMP10 values into different quartiles, and we see that the highest quartile for BMP10 in fact contained the largest proportion of patients who had recurrent AF. And on this right here, when we see the survival curves, we see a similar pattern where the highest quartile in purple had the highest recurrence rates over follow-up. Finally, this is what I think is a rather unique study with repeated measurements of biomarkers from 433 patients in the AXAFA AFNET 5 cohort. Blood was taken pre-ablation as well as at 3 months post-ablation. And we see here that the biomarker levels at both time points are actually quite highly correlated down the middle. When we look at the individual biomarkers, we see that elevated NT-proBNP as expected, also angiopoietin-2 and BMP10 at baseline was quite indicative of recurrent episodes within this short follow-up period. If we just compare the changes pre and post ablation for these markers which changed, we noted that there were these changes in 4 of the markers, whereas where there was a significant decrease in angiopoietin-2, BMP10, and NT-proBNP, but an increase for FABP3, which is fatty acid binding protein 3. Here we see the overall changes in dark blue for the first box plot, and then stratified by rhythm, arrhythmia-free in light blue, and those who had recurrence in red. And we actually see that the changes are all significant and driven by patients who remained arrhythmia-free. Finally, we observed that there are significant differences of biomarker levels between males and females, both at pre-ablation, and this was a pattern which persisted post-ablation, suggesting that there are inherent differences when we looked at biomarker levels in males and females, even after correction for all the possible variables that we noted were different between males and females. So this really strongly suggests to us that when we think about implementing these markers in practice, regardless of whether or not we use them as continuous variables or trying to implement a cutoff point, we really need to be mindful of these differences. So I will conclude now this touch and go of plasma biomarkers in AF. I will reiterate that even though I didn't mention them much in the talk, natriuretic peptides do remain as the biomolecules with the largest evidence base for their use in management of AF. We have several new markers such as BMP10, angiopoietin-2, insulin growth factors, etc., which have emerged in the past 2 years, and these will continue to be evaluated and validated. Understanding the dynamic changes of the biomarkers over time is something that I think is important to look at. Our understanding is improving, but we can work on this a bit further if we have more studies that have repeated measurements of biomarkers. And finally, just to highlight again that biomarker levels can be inherently different between women and men, and this is something to take into account both during implementation and also during interpretation of any results that come from these biomarker analyses. And with that, I'd like to acknowledge everyone involved in the work, especially the team at Birmingham, and thank you for your attention.